So I'm going to re-emphasize the fact that we're talking about wear and tear arthritis as opposed to the inflammatory arthritis. And I also want to re-emphasize the fact that Steve and other hip and knee surgeons talk about how important the hips and knees are. I also think that the shoulder's very important in terms of functional anatomy. The hip is built for stability and mobility, whereas the primary function of the shoulder is to put your hand where it needs to be. And I think we'll all acknowledge the fact that that's a very important function. I was intrigued with the photo on the left, which is basically an in utero surgery photo with a little tiny baby's arm reaching out at the time. If we then look at the anatomy beyond the functional anatomy, and we look at the bony anatomy, as Steve was also talking about, we basically have a ball in a socket when you look at it from the front. You can see the contour of the ball, and right here, again, a convex surface meeting a concave surface. And you'll notice right away that the socket is less deep or constricting or constraining than the hip socket is. And if you look at it from this projection, again, it does look like a ball in a socket. But if you look at it from 90 degrees, it looks more like a golf ball sitting on a tee. The ball is much bigger than the socket is, and so it's inherently unstable. Fortunately, we have a lot of soft tissue structures around that bony ball and socket that constrain or keep the ball within the socket. Otherwise, it would just want to fall out all the time. And those structures are ligaments, they're cartilage, and they're also the all-important muscles. Many of you have probably heard about the rotator cuff and rotator cuff muscles. And in addition to the function that they serve, they can also, all of those structures, the ligaments, the cartilage, and the rotator cuff muscles and tendons can also cause pain. So when we see somebody that has shoulder pain, we need to be sure that the problem is either a soft tissue problem or a bony problem. So we spend a lot of time frequently in terms of figuring things out. Some of the things that help us figure those out are X-rays. And many of you know that X-rays show us bone and the relative positions of bones to each other, but they don't show us those soft tissues. In this X-ray, which is a fairly normal X-ray, you see that there's a space in between the surfaces of the ball and the socket here. But if you actually go inside and look, there isn't a space there. That's the space that's occupied by the cartilage that Stephen was showing the slides of, but that doesn't show up on an X-ray. We can only infer what's happening to the cartilage with a plain X-ray by the lack of a space between the bones there, or an asymmetric space there. So this is fairly normal bony anatomy. Again, the ball, the socket, this is called the humerus or the humeral head, and the socket is actually called the glenoid. The collar, for orientation, the collarbone's up here. If we then look at the gross anatomy, I don't mean because it's an intraoperative photograph. Gross anatomy means that we're looking at the actual anatomic structures, and this is an intraoperative photograph of the ball that shows the surfaces analogous to the ones that Steve was showing in terms of this is actually not cartilage at all. This is bare bone. So all of the cartilage is gone, and then around it what you see are the bone spurring there. And we think the reason people have bone spurs when they have arthritis is that when the cushion between the bones has been worn away, what your body tries to do is distribute that force over a greater area. So it expands the surface area by making bone spurs around it. They're not quite as effective as the native cartilage surface that you had, but that may be a reason why we get the bone spurs. As Steve said, if you're here, you probably know how arthritis feels. And basically, it causes pain. And sticking with the osteoarthritis or wear and tear pain, it's usually worse with activities. Inflammatory arthritis, in our experience, is usually worse at rest. When you wake up in the morning, you may be stiffer, more uncomfortable, but osteoarthritis or wear and tear arthritis frequently gets worse with activity. Because your pain gets worse with activity, frequently your range of motion will decrease, your strength will decrease because when you use your extremities, you load the joint, which makes that pressure there on those bad surfaces worse. So you get sort of an inhibition or reflex inhibition of any lifting activities in an effort to protect yourself. So ultimately, it significantly compromises your quality of life. If we look at a spectrum of disease, once again looking at the X-ray, you notice that this joint space is a little more narrow than the normal or closer to normal X-ray I showed you before. So again, we're looking at the relative position of the ball and the socket there. But again, it's a very gross representation of what's actually going on in there. If we went inside and looked in that joint, chances are it would show the potholes that Steve showed. It'll show differences in the cartilage, differences in the thickness. And it also doesn't show us what the symptoms may be. It's a gross representation as opposed to progression of the disease, where you can see that the joint is pretty much worn out here. And again, you have these big signaling osteophytes here that look like they're just down here. But if you looked from this direction on FOSS at the ball, you'd see that they're all the way around it, sort of rimming the bone spurs. So the magnitude of the disease radiographically may not always correlate, or the magnitude of the presentation may not always correlate with what you're seeing on the X-ray. And again, as a general principle, Sohail early mentioned early on that we use surgery as a last resort, and I really think that's true. So we're treating a person who presents to us. We're not treating any of these X-rays exclusively. So we always want to start with the least invasive treatment, and as we need to, we move to the more invasive treatments. And in that vein, again, a lot of these principles are similar for the hips, the knees, and for the shoulders, and for the ankles and the feet, and probably the spine. So the first thing to do is to avoid the things that you know that make it worse. But there's sort of a compromise here in that we don't want you to completely stop all of your activities because one of your joints or two of your joints are bothering you. Our job is to help you stay doing what you want to do as much as we can, but you want to use common sense in terms of precautions. The most important thing for most of us are activities of daily living. We need to take care of ourselves. We need to take care of our families. So be sensible about it. If you know, and prioritize basically. If you know you're going to be doing something that's fairly vigorous, don't do it on a continual, regular basis and keep pounding on things. And as Steve mentioned, we also use NSAIDs or non-steroidal anti-inflammatory medications. And in terms of principles, osteoarthritis causes inflammation, and it's probably that inflammatory cascade which causes pain. So if you're avoiding things that you know that hurt, you're being careful, and you're still uncomfortable, if you take one of the many anti-inflammatory medications on the market, frequently that's all people will need to be able to do what they want to do. But you have to be careful because I'm sure most of you know that there are side effects associated with these medications. So even though they're over the counter, we don't take that lightly. Physical therapy, in my mind, in a situation of osteoarthritis, not rotator cuff tears or other problems in the shoulder, is important to help people maintain their range of motion as much as possible. We don't like to do a lot of weightlifting and those resistive type exercises in arthritis because, again, if you have weight in your hand and you're exercising your shoulder, you're basically increasing what we call the joint reactive forces, the pressure on those surfaces, by a significant amount. 10 pounds out like this can increase the joint reactive forces in your shoulder by almost 5 times your body weight at times. So you don't really want to lift weights if you're being treated in physical therapy for arthritis. You frequently do for the soft tissue conditions, the rotator cuff type conditions. So we talked about taking non-steroidal anti-inflammatory medications which give you a systemic anti-inflammatory effect. What the modalities do, and the modalities are ultrasound, phonophoresis, and iontophoresis, they impart an anti-inflammatory effect locally. So you're getting the systemic effect from the pills that you take. You get a more local, topical effect with the modalities in physical therapy, and frequently are helpful. Another principle is that in the aggregate, if you do all of these things, hopefully you'll be able to be comfortable for a long time. If we stay in the vein of going least invasive to most invasive, the next more invasive thing to do is to have an injection in your shoulder. And PRP and Synvisc, as Steve was mentioning, are treatments, they're injections, and the jury really is out in terms of randomized controlled trials and actual science in humans about whether or not these things really help and alter the course of disease. But anecdotally, certainly some people get better with these modalities. For me, the mainstay, once I start to initiate invasive treatment, is injection of steroid. And again, we've taken anti-inflammatory medications to decrease inflammation. We're doing local things and modalities to decrease inflammation. And now we're actually applying the most potent anti-inflammatory right where the problem is, right inside the joint. Not an injection in the bursa for your impingement syndrome or your rotator cuff, but right inside the joint, again, to most potently decrease the inflammation. How long these last is really variable, and I think there's an inverse correlation between how bad your arthritis is and how much relief you get from your initial injection and how long that injection may last. I'm fond of telling a story about a roofer that I'll usually see about this time of year every year because he's back up on the roof again, hauling things up, comes in, gets an injection, and then I won't see him again until next spring. But his arthritis isn't that bad, though yearly it's getting a little bit worse. So it's really variable in terms of how long it will help. And in terms of frequency of injection, which we're asked a lot, frequently, I think it's safe to do it up to 3 times a year, maybe every 4 months or so. But the reality is that in my patients, for the most part, the first injection gives them the most relief, and subsequently there's probably a little bit less relief each time. Once we've gotten to the point where we've done all the lesser invasive things, the primary indication in my mind is pain. And how fast we go down that continuum from the least invasive treatment, anti-inflammatory medicines and avoiding things, to where we get to this portion of treatment is purely dictated by patients in my practice. And so the indications to proceed with the most invasive treatment, i.e. surgery, is predicated on pain. And it's hard to quantify that. So what I usually say to my patients is that when you can't do the things, or you're unable to do the things you want to do because of pain, that's a big deal. But when you can't do the things you have to do because of the pain in your joint, that's probably time to do something about it. And so pain is a huge indication. And also the fact that you've gone through the lesser invasive treatments and you're still not where you want to be. There's never a convenient time in my mind to have shoulder surgery or shoulder replacement. And so I basically recommend to people that if we're going to go to that step to do something surgically, you need to have in your mind that you're going to devote 3 or 4 months to this in terms of getting back to where you want to be and carrying out your activities in a more comfortable fashion. Having said that, we then need to look at the different considerations that impact what we do and when we do it. One is anatomic, both the bony architecture that we've been talking about. Certainly that shoulder looks like it's worn out, and if I just looked at the X-ray, I would say probably time to have an operation if all the other modalities have not worked. And we also consider not just the bones that we can see, but I like to image people before surgery to look at the soft tissues. Remember, we're not seeing the soft tissues here, just the bone. There are an awful lot of situations with the soft tissues that will help us determine what will be the best surgical option for you. In particular, what your rotator cuff, the status of your rotator cuff is, because we depend on that to help us contain the components of a total shoulder just as your normal shoulder does. So we need to know whether or not that's intact or in good shape. We also need to know a little more about the socket, and you'll see why that becomes important over time as well. So we look at the anatomic considerations once somebody's come in and said they think they want to proceed with the next step. Age is important in that there is a longevity associated to these prostheses as there are in the hips, and our results are similar. At 10 years, probably 90% are doing well. At 15 years, 85% are doing well. At 20 years, 80% are doing well, just as a very rough ballpark. And we'll talk about some of the reasons that they don't do well after that over time. So the later it's done, probably we try to wait as long as we can without making somebody in a punitive fashion wait to have things done. So the youngest person I've ever done, I think, is 42, and the oldest is well up into the 80s. You also have to be cognizant of the activity level, as we talked about, being sensible about things. Expectations. Don't expect to be starting to play rugby if you haven't been before. Remember, the primary function of your shoulder is to put your hand where it needs to be in space. And then if we look at the risks of surgery, one of the most common complications of total shoulder surgery, in addition to the complications that people talk about with any kind of surgery, the specific ones for total shoulder replacements are loosening of the components, primarily the socket. And there's about an 11% incidence of loosening at 15 to 20 years. The stem side of it, the ball side here, and we'll talk a little bit more of that, there's less than a 1% incidence of loosening. But dislocation and loosening are probably the things we worry about the most. So there are risks associated with this surgery as there are with any surgery. If we then look specifically at the different procedures, again, in the vein of going least invasively to most invasively, we've already started the invasive treatment if you've had an injection before. So if we now look at an arthroscopy, as Steve said, this is a minimally invasive procedure in which we make 1 centimeter incisions. We put an arthroscope or a little lighted fiber optic tube into the shoulder. We have a camera and a monitor, and we go in and we actually look at the structures in there. And I think in the shoulder with arthritis, this is most effective. So this is cartilage, and this is bare bone in here, these potholes here, as Steve was talking about. So in my experience in shoulder arthritis for arthroscopy, the times it's most effective is if the arthritis has not end stage yet or not all the way gone, and that there are loose pieces in there or big flaps of cartilage that are actually causing mechanical problems. Frequently, we can improve that situation. The question is, how long is that going to last? In people who have end-stage arthritis who frequently will come in and say, isn't there something you can do besides injection before I have surgery? What about arthroscopy? And I'll be perfectly honest that in my experience, and I'm old, is that very few people get more relief with a shoulder arthroscopy for a debridement for arthritis alone, not the mechanical problems or the rotator cuff or whatever. They get not much of a difference over just having a steroid injection. So there's not a big difference unless there are mechanical situations in there that I can address arthroscopically. If we then become more invasive, we talk about arthroplasty, which is replacement. Arthro means joint and plasty means to replace basically or fake. So if we talk about a hemiarthroplasty, hemi means just half. So all we're doing in this is replacing the ball side. And there are specific indications for the ball side. One is, I keep mentioning the rotator cuff. Well, the primary function of the rotator cuff muscles are to hold the ball in the socket, as I mentioned, and to center that ball down on the socket so you have more even wear. In people in whom the rotator cuff is gone, and the ball rides up and bumps into this bone up here called the acromion, it's not in patient's best interest to have a, quote, total shoulder replacement, because when this ball rides up, it eccentrically loads this socket, and if you have a plastic socket in there, it will rock that, and it'll loosen it, and it'll loosen much more quickly. So in that setting, we're apt to just replace the surface of the ball, which doesn't provide as much pain relief as doing the ball and the socket, which we'll get to, but it's better than what was there. Previously, we would use, as Steve showed, the big stem coming down the shaft here. But most of those are made with interstices on the sides or a matrix on the side into which the bone can grow and hold it there. It's very strong. That's the good news. The bad news is if you've only replaced the ball and you haven't done anything to the socket and you want to do something to the socket down the road, if that becomes more symptomatic, it's really hard to get a stemmed implant out of there. So over the past 5 or 6 years, my partner John Bell and I have been doing these surface replacements, which still provide a new surface, a new bearing surface on the ball. But if it has to be revised down the road, it's much easier to get this out and to do a revision than if you have the big implant coming down here. And the surface that the socket sees is just the same as if we had a stemmed implant there. So that's a hemiarthroplasty. That's replacing half of it. There's a lot of discussion these days about reverse total shoulder replacements, which have been done in Europe for quite a while, and in the past 10 years have really increased in popularity in this country. The indications are very specific for this. It's especially helpful in people who no longer have any rotator cuff function, because the function of this implant, and the reason it's called a reverse, is that you'll notice the ball is on the socket side, and the socket is on the ball side. And the way it works is by counting on the deltoid muscle as opposed to the rotator cuff muscles. So the premise of how it works is completely different. The indications are very specific. The other part of this is that we don't know what the long-term outcome of these implants are going to be. Their complication rates, even in Europe, have been a lot higher than what we do whenever we can do, which takes us to the most common arthroplasty in the shoulder, which is the total shoulder replacement, which means replacing the ball and the socket surfaces. And the way I do this is it's an inpatient procedure. Most of the patients stay for about 48 hours in the hospital. It is an open procedure, a larger incision, as opposed to the arthroscopic incision. We like to say it's minimally invasive, but it always has been, as opposed to the hip and knee guys. So this is actually an example of an implant that may be used. This is that stem that goes down the hollow shaft of the bone. It has material on the side here to encourage the bone to grow in, sort of heals like a fracture does, if you will. This is the weakest, the fixation is the weakest when you put it in and becomes stronger over time, as opposed to implants that are cemented, that are the strongest they're going to be when you put them in, and they get weaker over time. We've been through a lot. This is also a modular prosthesis in that we put the stem down, and when we cut that ball off, we measure it, and we have an array of sizes. Well, we have an array of sizes of all of this, but we try to place the same, about the same size ball or head on there as the one we took off. The socket, however, we've found over the years, we've had metal sockets like the hip metal-backed sockets and those sorts of things. The state-of-the-art still in shoulder arthroplasty is a plastic or polyethylene socket or glenoid with pegs on it that we then glue in. We've come around, I've been doing this long enough that we've come around several times now. We've done the metal-backed glenoids in the past. They were a disaster. The newer ones are touted to be better, but I personally am waiting till we have more outcome studies with regard to the metal-backed glenoids, but a lot of people are doing those, and I'm not saying it's wrong. I just want to see more outcomes before I start doing them again. So this is, again, the gross picture intraoperatively. What we basically do is take off this arthritic head or arthritic ball, which then allows us to see, which you can't see. Now, this head is dislocated here, so we can work on it. We've opened up the rotator cuff, between the rotator cuff muscles, actually, to do this. And we've taken this, removed this arthritic articular surface or joint surface, which allows us to see into the socket. Here, you can't see the polyethylene socket because it's like the cartilage. It doesn't show up on an X-ray, but you can see the cement around the pegs here, and there's a little metal marker in here. So the socket is cemented, the stem is press-fit or bony ingrowth, and then we put the appropriate size ball on top of there. And then, most importantly, we make sure we close up the soft tissues, because if we're doing a total shoulder replacement, it means that the rotator cuff is either intact or it's repairable, so that we can safely place both the ball and the socket. Postoperatively, most people come in the day of surgery. They stay with us for about 48 hours. We start physical therapy. They go into a sling after surgery on the operating table. They start physical therapy the first day after surgery. And do it morning and afternoon that day. Stay another night with us the next morning if everything's going okay systemically and patients are comfortable. They have therapy in the morning and then go home. I do most of my total shoulders on Tuesdays. Most of them go home on Thursday mornings. And so there's a period of immobilization for about 4 weeks, anywhere 4 to 6 weeks, depending on how stable things are at the time of surgery. And we start the rehabilitation the day after surgery. We have a very specific protocol, so if people have it done here, but they go home other places, we have protocols that are portable, and a lot of people do that. The primary goal of rehabilitation in the first 2 to 3 months is to regain motion. You have the rest of your life to strengthen it, but you have a golden opportunity in the first 2, 3, 4 months to get motion back. So we focus on motion and then subsequently strengthening. This is an interesting slide for me because when Suzanne and the nurses were putting together a book for patients who are considering total shoulder surgery, she asked if they could contact any of my patients for a photograph. And I said, sure, call them and ask them if they'll do it. This person may be familiar to you, and the only reason the photo's up here is because he consented to have that picture taken for our brochure, and this is also on the internet. So when I was shown the picture of my patient, when they went out to his house and showed him splitting wood, I said, that really sends entirely the wrong message. But I really don't like people splitting wood after they've had a total shoulder replacement. It's analogous to the jackhammer. But I did his shoulder about 8 years ago, and he's still doing fine. So you have to, I think, in terms of expectations, you need to be reasonable. The primary goal is to relieve your pain, to improve your range of motion, to improve your strength, and overall to improve the quality of your life. So thank you.